Hello everyone. This you're seeing is a question paper of MBBS first professional examination of MBBS 2019 admitted batch under MJPRU Mahatma Jyotiba Phule Rohailkhand University Bareilly. Okay. Now this is a question paper of anatomy paper-2 and this exam was conducted on 6th of February 2021. This question paper was of 100 marks and out of this part A was of 20 marks, which includes 20 MCQs. So here I am uploading the answers to all these 20 MCQs with the explanations so that those who have attempted, they can check their answers, and those who have not attempted, they can just assess themselves. Okay, so now part A, question number 1. Which is the quadrangular chamber of the heart? I believe this was a very easy question. If you have read about the chambers of the heart, the first line you'll find in your notebooks about the left atrium, that it is the quadrangular chamber of the heart. Got it? So the answer to 1 was C. Okay. Now question number 2. Which statement is wrong regarding the great vessels of the thorax? SVC is 7 centimeter long. This is correct. The length of SVC is 7 centimeter, and for your memory comparison, remember that ascending aorta adjacent to is of 5 centimeter. Ascending aorta, it's of 5 centimeter, just adjacent to it, towards the left. Then right brachiocephalic vein is smaller than the left brachiocephalic vein. Exactly correct. You have this SVC formed by the 2 brachiocephalic veins. This one is the right, this one is the left, and this one is SVC. So left brachiocephalic vein, and because now I have got time, so I'm explaining it, and so you can remember for a long time. Remember that your Manubrium sterni lies here. So in case if it's asked like what lies behind the upper portion of Manubrium sterni, the answer is left brachiocephalic vein. And what lies below to the lower half of Manubrium, then the answer is arch of aorta. Okay, so this one again is correct. Got it? Ascending aorta is a content of middle media sternum. So I have started uploading lectures on heart also. So remember, you have this, this is the pulmonary trunk, and behind to that is this arch of aorta. This is ascending aorta. So this portion here, this much portion is covered by pericardium. And don't forget that this is the manubrosternal joint, and this lies at the level of T4 T5 junction. T4 T5 junction. So the content of middle mediastinum, remember, it's not only the heart but also the lower portion of SVC. SVC will be here, SVC, partly SVC, and just the end of this IVC, and the ascending aorta. Ascending aorta also is a content of middle mediastinum. That means it lies below the line passing through the sternal angle, and it's content of inferior mediastinum, but the contents surrounding they are said to be the contents of middle mediastinum. For your remembrance, this is going to be long, so just for a long time I'm just making this video. So remember that this sternal angle, it's the ascending aorta, then it arches like this, and then it descends like this, right? This is the way it descends, right? So it's this. So this, this line here, sternal angle, ascending aorta terminates at the level of sternal angle, arch of aorta commences and terminates at this level, and then descending thoracic aorta begins at this level. So ascending aorta, all you are seeing is here, this is all a content of middle mediastinum. Okay, so that means this statement is also correct. Now D is anterior margin of the left lung and pleura lie in anterior relation to the ascending aorta. So here you have seen that actually, let me draw this SVC will be here, SVC will be here. It also is partly content of middle mediastinum, and this is the right atrium, and here you find in the inferior vena cava. So and you know that we will be talking is about the lungs. So let's say lungs, it's here, and here is the cardiac notch along with the pleura. So don't forget that the ascending aorta actually is lying behind to this anterior border. Hold on, this isn't notched. Ascending, this is the anterior margin of the right lung. So ascending aorta lies behind the anterior margin of the right lung and right pleura. So the answer here will be, because this is the wrong thing, and then you answer because it was asking the wrong statement. So your answer will be, what will be your answer then? Your answer will be D. Got it? This is the wrong statement. Okay, it's done. Now question number 3. Which of the following structure is not seen in a transverse cut section of thorax passing through the 5th thoracic vertebrae? Remember why I was explaining you the above question, so that you can solve any other relevant question to this. This is a hit topic, the sternal angle, sternomaneuveral joint. I think there was a theoretical question also on this joint, manuverosternal joint, in the same paper. So the manuverosternal joint posteriorly passes between T4 and T5 vertebral level. That means above to this will be 4th thoracic vertebrae, and below to this level will be the 5th thoracic vertebral level. Now they have asked which of the following structures is not seen in transverse cut section. That means we are talking is about the section. This is T4 vertebral level and this is T5 vertebra. So they're passing about the plane passing here to the T5, just below to the sternal angle, and the level of sternal angle is the junction of superior and inferior mediastinum. So not seen. What will you not find in this transverse plane passing to T5 vertebral level? Left pulmonary artery. Now pulmonary artery, you know that this pulmonary artery, actually pulmonary trunk, divides into 2 terminal branches, right and left pulmonary arteries, just below to this level of sternal angle. So this pulmonary artery, left pulmonary artery will of course be seen in section passing through the fifth thoracic vertebra. In fact, you will see the bifurcation of this pulmonary trunk into right and left pulmonary arteries at the level of T5 vertebral level. Okay. Then left principal bronchus, you know that, let me extend this line to explain you other structures. So trachea, trachea divides into two principal bronchus at the level of sternal angle. Now this is in supine position, right? Supine, vertical, erect posture. So there you find carina at the level of sternal angle, right? That means upper border of T5. So left principal bronchus will of course be seen in a transverse section passing through the fifth vertebrae. Left superior intercostal vein, you have been taught about the venous drainage of the thorax, that is the azygous system, right? So if you remember, there was first, second, third, fourth, there were 4 intercostal veins on the left side. They were draining into the left superior intercostal vein. Then 4, 5, 6, 7, 8, they were joining to form accessory hemiazygous vein, and 9, 10, 11, 12, they were joining to form the hemiazygous vein. So this of course is going to be a content of superior mediastinum, left superior intercostal vein. So it will not be crossing this fifth thoracic vertebral level. Fifth thoracic vertebral level is here, T5. Okay. Ascending aorta. Now ascending aorta, T5 पे अभी बताया था just कि you have this heart placed here. Pulmonary trunk I have already shown you. Ascending aorta begins here below and then it continues as arch and then thoracic aorta. So actually ascending aorta terminates at this level of sternal angle and it is completely a structure of middle mediastinum, right? So ascending aorta you are going to find in the section of T5. This is the section of T5. Okay. So your answer will be left superior intercostal vein. You have got the answer here. Left superior intercostal vein is the answer. Okay. So 3 is C. Next question. Which statement regarding the fibrous skeleton of the heart, let me make some space so that I can describe this in detail. Yes. So now you're saying is which statement regarding the fibrous skeleton of the heart is incorrect? Okay. So I think, this is really, really important, and don't think something to be out of your syllabus. This, skeleton of heart is one of your competencies in your syllabus for anatomy paper 2. So you should know actually what is fibrous skeleton of the heart, but I am not going to spend the time in describing all this. In short, I'll just brief it here. Look, the musculature of the two atria is separate and musculature of the two ventricles is separate, right? And the musculature is separated out by this fibrous skeleton of the heart. So you have the two atria lying above and the two ventricles lying below. So this fibrous skeleton actually is meant, the purpose of this is, fibrous skeleton between the musculature of atria and musculature of ventricles is to provide attachment to these muscles, right? You have studied so much about the muscles, they need some point of attachment to something rigid and fixed. So that's why the muscles of the atria, the cardiac muscles, they're attached to this on the upper surface, and the muscles of the ventricles are attached to the under surface. And don't forget that there is this membranous portion of the interventricular septum. So that also is attached to this fibrous skeleton. So you have, one thing is muscles of the atria, second is muscles of the ventricles, and third that is attached is the membranous portion of the interventricular septum, that also is attached to this. Then when you'll see it from above, this is actually like this. You have an opening here, that is the tricuspid opening. Then you have is the mitral opening. Tricuspid, you can draw it like this. It has 3 walls, right? And this is bicuspid or mitral valve on the left side. And anterior to that is the aortic valve with, it has 3 cusps like this. And anterior to that is the pulmonary, right? Pulmonary trunk, the walls, pulmonary walls. Now all these rings you are seeing is they have to have a rigid fibrous skeleton. The reason is, one thing was to, the purpose of fibrous skeleton is 2. One, I told you, is to provide attachment to the cardiac muscles, and the other is to maintain the patency or competency of these walls. Remember, they have to work the life long, so they shouldn't get collapsed along the circumference. So to maintain this circular diameter, to maintain the diameters and to prevent them collapse, you need to have a rigid fibrous ring along all these 4 walls. So that means they are also formed by rigid fibrous skeleton. And to provide support, now look here, the intervening space here, the intervening fibrous tissue condenses, and they, this what I'm drawing is intervening connective tissue, dense fibrous connective tissue. Actually, this blends and condenses to form a part of the fibrous skeleton, anchoring these 3 walls. This is the pulmonary valve, and this is this pulmonary valve. This is the, or you can say the better word is the right AV valve. Okay, and this is the left AV valve. This is the aortic valve, and this is the pulmonary valve. So this triangular connective tissue is called trigonum fibrosum dextrum. And just towards the left you have another fibrous band, and this fibrous band is connecting the aortic opening to the left AV valve, and this is called trigonum fibrosum sinistrum. Okay, and apart from this, there is also an infundibulum which connects this posterior surface, just adjacent to this pulmonary wall. On the posterior surface of the infundibulum of the right ventricle, there is this, infundibulum which actually connects to this aortic wall. So all these 4 walls, they get support together, and all it is made up of fibrous connective tissue. Got it now? So that diagram what you're seeing is that of the skeleton of the heart. And one more something interesting for your knowledge, that in some mammals you find even a bone that develops in this trigonum fibrosum dextrum. And like in case of sheep, this sheep's mane, you have a bone here called os cordis. So that was about the skeleton of the heart. I think you've understood it. Now let's read the choices. Okay, so I think I'll have to rub this out. Yes. So now read here. Which statement regarding fibrous skeleton is incorrect? They've asked is what is incorrect. A mass of fibrous tissue which binds the two atrioventricular rings to the aortic ring in front is known as trigonum fibrosum dextrum. I just show you that this one is a correct statement. And they have asked is incorrect. A mass of fibrous tissue present between the aortic ring and the right atrioventricular ring is known as trigonum fibrosum sinistrum. No, this should be left. Remember the diagram? This connects between this, trigonum fibrosum sinistrum connects the aortic ring to the mitral ring or the left AV ring. So this is a wrong statement. Now, tendon of infundibulum binds the posterior surface of infundibulum to the aortic ring. I told you this is the correct choice. Then membranous part of the interventricular septum is attached to the fibrous skeleton. I told you this is also correct. So your answer to this question will be, because they have asked the incorrect choice, so the answer will be B. So your fourth question answer is B. Now fifth question is about the typical intercostal nerve pierces which muscle to terminate in the end as the anterior cutaneous nerve of thorax. It also is easy, although you have this sternum here, right? And to the side of the sternum, let's draw the other way. You have this manubrium here, then you have is the sternum here, right? And you have the ribs here. This is second rib, right? So you have the ribs placed here like this. Okay. Now tell me, they will have this costochondral junction. Remember, these are the primary cartilaginous joint, except these are the secondary cartilaginous joint, except the first one, which is a primary cartilaginous joint. Now what I'm asking is, what lies, if you're dissecting it out and you're seeing it from front, what lies here in between the interchondral portion on the two sides of the sternum, most anterior after dissecting pectoralis major? Remember, you will find in this direction, and that is what is it? This is external intercostal membrane. Remember, there is no external intercostalis is not present in the interchondral portion anteriorly, and deeper to that will be in this direction, and that is the internal intercostalis muscle. So internal intercostalis muscle will be seen like this. This is internal intercostal muscle, and this one is external intercostal membrane, right? This is not a muscle, this is a membrane. And deeper to that, deeper to external intercostal muscle, deeper to internal intercostal muscle, you will not find that that intercostalis intimi. Rather, you will find the part of transversus abdominis, and that is called sternocostalis. So here you find is sternocostalis running like this. And now to draw it in another view, this I'm drawing is like this. This is the sternum, right? And I'm drawing it in layer by layer. So this you're seeing is external intercostal membrane. And after this costochondral junction, you will find it continues as external intercostal muscle. So this is external intercostal muscle, and this is external intercostal membrane. one thing. The next thing you will find is internal intercostal muscle. Now this is internal intercostal muscle. This is muscle. Deep down to that, you will find another third layer, and that is transversus thoracis. Transversus thoracis is in three parts. In the middle 2/4 you have intercostalis intimae, posteriorly you have subcostalis, and here you have is sternocostalis, right? And the neurovascular plane in this is between the inner two muscles. So the nerves and vessels will be running here. It's like this. The nerves and vessels will be running here. So if this is intercostal nerve, it passes here in between the inner two layers of the muscle. When it reaches here parasternally in the interchondral spaces, what it will pierce? It will pierce this muscle, internal intercostal muscle. Then it will pierce this muscle, this membrane, external intercostal membrane, and it will further pierce another extrinsic muscle attached on the lateral border of the sternum and onto the outer surface of this membrane. This is pectoralis major. Got it? So these are the three layers it will pierce. Number one, remember, it will pierce this. Second, it will pierce this membrane. Third, it will pierce this pectoralis major. And in case they still ask what further, it will pierce, of course, it will pierce the pectoral fascia. Pectoral fascia number 4. Okay. So these are 4 structures which this anterior cutaneous nerve of intercostal nerve, the terminal branch anteriorly, this will be piercing so many 1 2 3 4 structures to become cutaneous. So sternocostalis will stay behind. Got it now? We've understood. So let's check the choices. Answer yes. So typical intercostal. Now typical means what were the typical intercostal nerve? This again it's a question in itself. So T3 to T6, they are typical, right? That's why the typical has been written. Why? Because remember, down below the nerves become thoracoabdominal, T7 and onwards, and first and second are atypical because first is part of brachial plexus and second is also reaching to the axilla. So we don't consider this as typical. Typical is only to this T3 T6. Now nerve pierces which muscle to terminate in the anterior intercostal nerves? Answer I have already told you. External intercostal muscle will be the wrong choice. Internal intercostal muscle, it will pierce. Intercostalis intimae, I just told you, it is only in the lateral 2/4 of the intercostal, middle 2/4 of the intercostal space. Sternocostalis stays behind to the nerve. So the answer will be internal intercostal muscle, and that is 5th B. Got it? Okay. Question number 6. Here we begin the lower limb questions. Question number 6 is Perthes test for varicose veins of lower limb is done to detect the competency of. Let me tell you, you must be knowing there were 15 marks long question on the venous drainage of lower limb in the same question paper. And this, if you add this question MCQ, it becomes 16 marks. So this was rather a guess for you to cover up that clinical portion of the long question. If you would have been knowing this, you could have added this short note of clinical point onto the long question. So they are talking is about the Perthes test for varicose veins. Yes, so remember there are actually test for superficial veins and perforator veins. These two tests are being done by a test called Trendelenburg's test. Trendelenburg's test. Now, Trendelenburg's test, I'm not going to tell you the details. Maybe sometime I'll upload a video. Right now, just focus on superficial veins and perforator veins. Trendelenburg test, that is with the help of a tourniquet or placing a thumb at the saphenofemoral junction and all. You will just have to, drain the milking of this, draining the venous blood back into the femoral vein, and then asking the subject to stand up immediately. If there is like a gurging of blood again into the varicose veins, that means it's the superficial veins that we are checking. Perforator veins, you don't remove your thumb or the tourniquet and ask the subject to wait for 1 minute or then you will find again the gushing of blood and that superficial vein get filled up. That is about the perforator veins. So these two veins are checked by Trendelenburg test. But about and even this of course will be the same as along with this Trendelenburg test, that also can be checked along with the superficial veins. The D choice valve present at the saphenofemoral junction can be checked along with the superficial veins. Now what remains is the D choice. Yes, deep veins. Now deep veins are actually checked by this Perthes test, and that is like tying a elastic or tough bandage from toes to the upper one third of the thigh, so that your superficial veins, they all get compressed and the venous blood reaches to the deep veins, and you ask the subject to walk for around 5 minutes. So if the deep veins are competent, there is no thrombosis, the vein blood will be sucked up. But if there is venous incompetency or there will be thrombosis of the deep veins, this person will start feeling severe agonizing pain in the calf, because the gastrosoleus is trying to push up the blood, but there is valvular incompetency or there will be thrombosis of the deep veins. So there will be severe agonizing pain if there is incompetency of the deep veins. So that is about the Perthes test. And some even say that you tie a tourniquet at the upper one third of the thigh and ask the subject to walk for some time, and then there will be gradual filling of the after draining the superficial veins. You tie tourniquet at the upper one third of the thigh and ask the subject to walk for 5 minutes, and then there will be gradual filling of again these blood. So that means there is incompetency, and because you're actually walking and for a short while staying on the toes. When you stand on the toes, you actually gastrosoleus contract. So still, if your venous blood there is varicosities even after standing on toes and walking for 5 minutes after the tourniquet been taught and the upper one third of the thigh. So that means that these deep veins, they are still incompetent. So this is all what is being done in Perthes test. You can go and read about this. This is about Perthes test. It is to check the incompetency, or rather the competency of the deep veins. Question number 7. All are the muscles of the back of thigh except this. I suppose was very easy type of question. They are asking is about the hamstrings. Hamstrings, there are 4 hamstrings: semitendinosus, semimembranosus, adductor magnus. Remember the ischial head, or you can write as vertical fibers of adductor magnus. This is the hamstring, and you have biceps femoris, long head. Only these are the 4 muscles which are hamstrings. So among this, quadratus femoris, remember, is a muscle of gluteal region. So the answer to 7th is C. Okay. Now what they have asked is about the recurrent genicular nerve is a branch of. So remember, you have femur, you have this is tibia, right, and you have fibula. So this nerve, common peroneal nerve, descends down along the neck of fibula, and it terminally divides here under this cover of peroneus longus into 2 terminal divisions, the deep and the superficial peroneal nerve. for the front of leg is deep peroneal nerve for the front of leg, and superficial peroneal nerve for the lateral compartment, and this one is common peroneal nerve. So the important thing is that before terminally dividing, the common peroneal nerve gives out its last branch. The last branch of common peroneal nerve is this nerve, and it ascends up back to supply the knee joint, and this nerve is yes, this is recurrent genicular nerve, the last branch of common peroneal nerve. And additional to your knowledge, that if it is asked like recurrent genicular nerve supplies which muscle. So while in its course to supply the knee joint, right, because it's a recurrent thing, it goes upwards back. In its course, it also supplies the muscle here in the front of leg arising from tibia. Which muscle is that? Tibialis anterior. So in its course, this recurrent genicular nerve also supplies tibialis anterior. So I hope you understood that all of the branches. What was the question? Yes, recurrent genicular nerve is a branch of, answer will be common peroneal nerve. Answer is 8th ka B. Okay. Next question is, saphenous nerve is a branch of, very easy, simple question, common question. Remember, femoral nerve, after let me explain this short while. If this be the thigh, right, and there you have ASIS, pubic tubercle, this is inguinal ligament, and you know that femoral nerve descends below which point? Mid-inguinal point or midpoint of inguinal ligament? This another is an MCQ for you. So remember that femoral nerve is running lateral to the femoral sheath. Here you finding is the femoral sheath. So it runs down, and femoral artery is running in the lateral compartment. It is passing below the mid-inguinal point. This point is mid-inguinal point where this femoral artery descends down. So now they're talking about femoral nerve. Femoral nerve passes below this point, and this point is called midpoint of inguinal ligament. Midpoint of inguinal ligament, below to which it passes. It soon divides into a superficial and a deep branch, right? Superficial branch will give what nerves? Of course, medial cutaneous nerve of thigh, intermediate cutaneous nerve of thigh, and this intermediate will give a branch to sartorius also. The deeper branch is a muscular. It gives branches to rectus femoris. Remember, this rectus femoris will also give a branch to the hip joint, nerve to rectus femoris, and it will give branches to the three vastus lateralis, medialis, and intermedius. This I am talking is, for those who haven't understood, this is the posterior division and this is the anterior division, or you can, this is a superficial division and this is the deeper division. Okay? So this is anterior division, this is posterior division. So, and this nerve to vastus intermedius also gives a branch to which muscle? Small little muscle, and that is articularis genu. And these three nerves to the three vasti also, they descend down to supply the knee joint as well. But the important thing is what they've asked them the question. So remember that saphenous nerve is arising from the posterior division of femoral nerve, and it stays deep. Although it's a cutaneous nerve, but it stays deep. It runs within this. What is this? Any guesses? Yes, it's a content of adductor canal. So after passing out the canal, now it pierces the deep fascia at the level of the transverse crease of the knee joint, and then it's here that it becomes cutaneous, and now it descends down in the front of the leg, running over the shin, and supplies the skin of the medial malleolus, on the medial border of the foot up till the ball of the greater toe. That's so much long distribution, but when it emerges out from here, it soon gives its recurrent branch to the skin covering the patella, and this is called, this actually is a recurrent branch from the saphenous nerve, and it supplies the skin over the patella, infrapatellar nerve. All this plexus from the three nerves to vastae, not to the vastae, this cutaneous nerve, intermediate cutaneous nerve, medial cutaneous nerve thigh, intermediate cutaneous nerve thigh, and there will be a lateral cutaneous nerve. Remember, that is a separate nerve from lumbar plexus, lateral cutaneous nerve thigh. The three cutaneous nerve thigh and this infrapatellar nerve together form a prepatellar plexus to supply the skin over the patella. So your answer to this question is solved now. Remember, this nerve, saphenous nerve, is a branch of posterior division of femoral nerve. Posterior division of femoral nerve is the right answer. Ninth answer C. Okay. Chronic enlargement of prepatellar bursa. It was a simple and an easy question, very commonly being taught, and this is housemaid's knee. Housemaid's knee bursitis is called, prepatellar bursitis is called housemaid's knee. Now, what is clergyman's knee? Of course, it's also bursitis of infrapatellar bursa, right? And what is toddler's knee? Toddler's knee is actually the bowing of the legs in a toddler less than at the age of 2-3 years. These are the bowing of the legs, maybe because of the rickets also. So that bowing of the legs is called toddler's knee, means, genu varus type of problem. Miner's beat knee. What is that? Miner's beat knee is now as a professional hazard or the occupational hazard. People who work in mines, they have to crawl on their knees. So they developed osteoarthritis because of that. So osteoarthritis in people who are working in mines is called miner's beat knee, right? So this is related to osteoarthritis. Oh my God, there's less writing. Osteo, बस इतना लिख दिया, it's enough. Osteoarthritis. Have you understood now? Prepatellar bursa is known as housemaid's knee. Prepatellar bursitis or chronic enlargement. Housemaid's knee. That means 11th answer C हो गया. Now about regarding peroneal artery, which of the following statement is correct? Correct क्या है peroneal artery से related? Again, focus on. You are seeing is the back of leg, and there you find is femur, and here you have is tibia, and here you have is fibula, right? This is fibula. So, what muscle takes origin from the posterior surface of fibula? This muscle is flexor hallucis longus. Remember, I told you about this. There will be a crossing thing happening. And what muscle arises from the posterior aspect of tibia? This muscle is tibialis. No. This is flexor digitorum longus from the behind the tibia. So remember what I told you, that behind this flexor retinaculum there will be crossing out these tendons, because this will have to go medially in the sole and this will have to go laterally in the sole. So there will be a crossing of these tendon outside the retinaculum. Now Because, and you know about, there will be an obliquely placed muscle here, triangular muscle here, arising from the lateral condyle of femur. This muscle is popliteus. This is popliteus. So this artery descending down from the popliteal fossa is popliteal artery. I'm using the pink color for this. So as this artery, popliteal artery, when it reaches at the lower border of popliteus, remember, popliteal artery divides into two branches. Here you have from medial to lateral, there is interosseous membrane, right? The direction is like this, interosseous membrane from medial to lateral downwards towards fibula. So now this artery will terminally divide into anterior tibial artery, which will move in front of the interosseous membrane and reach into the front of leg, while the posterior tibial artery will descend down here, right? Will descend down here. But because there is a muscle arising from the interosseous membrane posteriorly, and that muscle is tibialis posterior, which I haven't drawn here. So this posterior tibial artery will be running on the tibialis posterior in between, and it will descend down like this. But because the back of leg is big enough, it have enough of tissues, this artery alone is not sufficient, especially the lateral compartment. There is no artery in the lateral compartment of leg. So what happens is that this posterior tibial artery, around 2.5 centimeter below the lower border of popliteus, it will now give its lateral branch, and this artery is the largest and the longest branch of posterior tibial artery, and that is peroneal artery. And this is posterior tibial artery. So peroneal artery is the longest and the largest branch of posterior tibial artery, given out 2.5 centimeter below the lower border of the popliteus, and it will run down here in the there's a posterior lateral intermuscular septum which separates this peroneus longus and brevis from this flexor hallucis longus. So it stays there here in the posterior compartment adjacent to that membrane. And don't forget, there is a nerve here also running down, and this nerve is tibial nerve, the nerve of the back of leg. Tibial nerve will also give its branch to this flexor hallucis longus, and this nerve is nerve to flexor hallucis longus. So here you're seeing that peroneal artery runs along with the nerve to flexor hallucis longus. I hope you understood this. Okay, now let's move to the question. The choices here are: regarding peroneal artery, which of the following statement is correct? It is the largest branch of popliteal artery. I just told you this. Correct. Begins 2.5 centimeter above the lower. No. What have they asked is regarding? Yes, this is not correct. Question क्या है, ध्यान से पढ़ना चाहिए. Regarding peroneal artery, which of the following statement is correct? They are asking correct. So this is the largest branch of popliteal. No, it is not a branch of popliteal artery. Peroneal artery is a branch of posterior tibial artery, not a branch of popliteal artery. So it's wrong. It begins 2.5 centimeter above the lower border of popliteus. I told you it's wrong. This peroneal artery is given off from posterior tibial artery 2.5 cm below the lower border of popliteus. In its course, it is accompanied by the nerve to flexor hallucis longus. I have told you the entire thing about this. So the correct choice, what they have asked is the correct choice. The correct choice will be C. अब बचता क्या है? It terminates in the sole in the form of lateral plantar artery. No, what is that continues as lateral plantar artery? Any guesses? Remember, it is posterior tibial artery, that continues as lateral plantar artery in the sole after giving its minor terminal branch, and that is medial plantar artery under the cover of flexor retinaculum of the leg or the ankle. Right, so posterior tibial artery continues as lateral plantar artery. 11th answer is C. Okay. Twelfth question. Question number 12. Skin of the posterior two-thirds of the scrotum or labium majus is supplied by. Fast revision. This is about the nerve supply of genitalia, right? So, and you can draw it like this. This is the perineum below to this. Here will be the anal opening, right? And this you can draw it like this in a lithotomy type of position. So, it will be better to understand. So, skin of the posterior to the scrotum. So, we are just covering up the oh shit. Let's be fast. This is the glans and there is the scrotum, right? Anal opening. These are the the groins, and these are the gluteal folds. This is lithotomy position. Now, about the nerve supply, the talking is. So remember the this dorsal nerve of penis. The dorsal nerve of penis supplies the cutaneous supply to the glans and the skin covering the penis, the entire shaft of penis. All this is by dorsal nerve of penis, and itself is a branch of pudendal nerve. Okay. Then talking about the nerve supply of the root. This is the root of the penis. The root of the penis and the anterior one-third of the scrotum. And remember, if it are like a female, it will be this clitoris by dorsal nerve of clitoris. Similarly, upper one-third of the genitalia, that will be labium majus, will be by the same nerve. Here it will be by the two nerves. Remember, ilioinguinal nerve and genital branch of genitofemoral nerve. These two nerves will be supplying the skin of the root of penis and the anterior one-third of the scrotum or labium majus. Now about the posterior two-third. I think I should tell you that this is the anterior one-third. This is one-third. And now talking about the posterior two-third. This is two-third. Posterior two-third of the scrotum is this. Now, in this posterior two-third, we divide into median and lateral parts. So, let's say this much is the medial portion, and it will reach along to the anus as well. So, this much portion here in the midline, the medial two-third of the posterior two-third, this is by posterior scrotal nerves, which are branch of pudendal nerve, right? However, the lateral portion, I should use some different color. Okay, so the lateral portion of the posterior two-third of the scrotum along this, this portion, if you talk about the gluteal region, what is natis? I believe you know what is natis. Natis, if you see the buttocks or the gluteal region, the lower inner quadrant is called natis, right? And natis has been supplied by two nerves. One is the perforating cutaneous nerve. These are the perforating cutaneous nerve which will supply perforating cutaneous nerve, and the posterior cutaneous nerve of thigh. Posterior cutaneous nerve of thigh. So posterior cutaneous nerve of thigh not only supplies the back of thigh but also gives a branch to the lateral portion of the posterior two-thirds of the genitalia, that is labia majus or scrotum. Right. So among the choices, remember this posterior scrotal nerve has not been mentioned. Right. Only this red color, that is the posterior cutaneous nerve of thigh, has been mentioned. So now let's see the choices. Skin of the posterior two-thirds of the scrotum or labia majus is supplied by ilioinguinal nerve, anterior one-third, and the shaft or root of penis, genital bone of the genitofemoral nerve, no, anterior one-third of the scrotum and the root of the penis, right? Femoral branch of genitofemoral nerve, this supplies the skin over the roof of femoral triangle. Femoral branch of genitofemoral nerve supplies skin of the roof of femoral triangle in the front of thigh. So posterior cutaneous nerve of thigh, this will be your answer. Got it? However, it supplies skin in the posterior two-thirds of the scrotum only on the lateral side. But there is no other choice correct except this. Got it? Okay, so the 12th answer was D. Then dartus muscle in scrotum is a modification of. So it's an easy thing. Let me tell you that the skin in the lower half of the superficial fascia in the lower half of the abdomen, right? In the lower half of the abdomen, the superficial fascia here, it is made up of, and here you have genitalia, you have the thighs here. So you remember that the superficial fascia in the lower portion of the abdomen has two layers of superficial fatty layer called fascia of Camper and a deep membranous layer, that is fascia of Scarpa, right? So remember that fascia of Camper, that has mainly fat, superficial fatty layer, when it descends down its scrotum, it becomes devoid of fat, and the muscle, that is subcutaneous muscle, like the muscles of the facial expression, right? Palmaris brevis, all these are examples of subcutaneous muscles. Sorry. So dartus is a subcutaneous muscle found in the fascia of Camper. However, fascia of Scarpa also continues, this membranous layer superficial continues as fascia of Colles fascia in the perineum. In this scrotum, Colles fascia is the same as, which is continuation of fascia of Scarpa in the perineum. Internal oblique, they all like internal those cremastic fascia. So we are not talking about all that, right? The answer will be here. The answer is fascia of Camper. To remember which is superficial, which is deep, remember C comes before S. So C is superficial to S, right? So Camper lies above, that is superficial fibrofatty layer. Superficial fibrofatty. Superficial fatty layer, that is fascia of Camper, and Scarpa is deep membranous layer, right? This continues as Colles fascia, and dartus is an example of superficial layer. So 13, your answer will be A, fascia of Camper. Question number 14 regarding celiac trunk and its branches. This I think I have taught you in my some time back. Similar question regarding branches of the celiac trunk. So remember, now we're talking is about celiac trunk, right? The celiac trunk T12L1 junction, there is this anterior midline branch from the abdominal aorta, right? So left gastric artery is its smallest branch. This is the correct statement, and what they have asked is the wrong statement. Now splenic artery runs behind. No, this is the wrong statement. Remember, splenic artery runs on the upper border of the pancreas. What runs behind the pancreas is pancreas. Oh, this is splenic vein that runs behind the pancreas, not the artery. And artery, another point about is that it has a tortuous course. Right gastric artery is a branch of proper hepatic artery is a correct statement, although you might find somewhere some people might have written as a branch of common hepatic as well. But remember, it has a lot of variations, but the dominant, the majority of the prevalence of this hepatic artery, right gastric artery is from this. There's a lot of papers published even, and they are even in your textbook, the book you read, you'll find that right gastric artery is a branch of proper hepatic artery. This is more common, prevalence of this origin of right gastric artery. The short gastric artery are branches of splenic arteries, correct. So your answer is this. Splenic artery runs behind the surface of pancreas is a wrong statement. So this becomes your answer. 14th का आंसर क्या हो गया है? B. Okay. Now 15. Question number 15. Which of the following is a wrong statement regarding the arteries and their immediate source? Superior rectal artery is a branch of inferior mesenteric artery. It's a correct statement. Correct, right? Although writing it as a continuation of the inferior mesenteric artery would be even more proper to write, but this also is correct if you say it's a branch. Continuation would have been a better word. Now, artery to ductus deferens is a branch of superior vesicular artery is also a correct choice. Artery to ductus is a branch of superior vesicular artery. Let me ask you another thing, like cremasteric artery, like these are the contents of scrotum I'm asking. Cremasteric artery is a branch of, so remember this point here I'm telling, because it's all related to the genitalia and the scrotum. So ductus deferens, artery ductus is a branch of superior vesicular artery is correct, and then cremasteric artery is a branch of inferior epigastric artery. Remember this. And inferior epigastric artery is a branch of external iliac. Okay. The deep one, like not the superficial. Superficial though uski femoral artery की branch है. Superficial inferior epigastric. We are talking about the deep branch. Inferior epigastric artery की branch क्या होती है? Branch to artery to cremaster. That is just for you add up knowledge. Now question number C. Inferior gluteal artery is a branch of anterior division of internal iliac artery. Correct. However, remember the superior gluteal artery is a branch from the posterior division or the dorsal division of internal iliac. Then lateral sacral arteries arise from the anterior. No, this is the wrong thing. They will arise from the posterior or the dorsal division of iliac artery. So remember, lateral sacral arteries arise from the posterior or the dorsal division of internal iliac artery. So your answer, because they have asked to select the wrong statement, so your answer will be D. 15th answer is D. Regarding the blood supply of rectum and anal canal, which statement is false? Again, in your theory paper, there is a long question on rectum of 15 marks, and if you add up 1 mark from here, it becomes 16 marks. Rather, it is a help for you. Rather, if you know to solve this MCQ, you can write the blood supply of rectum there in your text. So regarding blood supply of rectum and anal canal, which statement is false? Wrong statement batana hai. Superior rectal artery supplies blood only to the upper part of the rectum. यही false statement है. बाकी सब तो देखते हैं. Middle rectal artery supplies only the superficial course of the lower rectum. This is correct. Remember, it is supplying, it's a superficial, and even sometimes even not present middle rectal artery. It supplies only the superficial layers. Correct. Then inferior rectal artery supplies the anal canal below the pectinate line. Yes, inferior rectal artery is actually a misnomer. If you go to my lecture, there's already a lecture in my channel on the rectum, in a long detailed lecture. They'll find the details about this blood supply. You'll get to know that inferior rectal artery is a misnomer. This is a misnomer. Why misnomer? It doesn't supply rectum, it only supplies anal canal, and that also below the pectinate line. Okay, so this is a correct statement here, that it supplies anal canal below the pectinate line. Median sacral artery supplies the posterior wall of the anorectal junction is correct. It is descending on the antisurface of the sacral vertebrae. It's a median unpaired artery, right? And it supplies the rectum and anal canal at the anorectal junction posterior is correct. So your answer here is, remember that superior rectal artery, remember important point I'm telling is, superior rectal artery supplies blood to the entire rectum, including the upper 1/3 of anal canal, that is above to the pectinate line. Got it? So your this actually is a false statement which ultimately becomes your answer. Okay, for details you can watch the entire lecture on this in my channel. Question number 16 is done. Question number 17, histology. Medullary cords and medullary sinus is a feature of. सुपरहिट क्वेश्चन था, यहाँ पे एफरेंस होते हैं लिम्फ नोड में. एफरेंस का वॉल किस डायरेक्शन में होगा? ऐसे होगा. So these are the afferents, these are the efferents of the lymph node. Efferents के valve ऐसे होंगे, right? And when lymph enters, there is a subcapsular sinus. These are the trabeculae. These are the trabeculae, subcapsular sinus. And when these trabeculae reach deep inside, they anastomose and they join with each other like this. So what happens is, they form this. What is this called? Medullary sinus. And the lymphoid tissue interpresent between the lymphoid tissue here, interpresent between like this. Now this is medullary cords. Medullary cords. So medullary sinus, medullary cords, they are feature of lymph node. Got it? Is a feature of, answer is lymph node is the correct answer. 17th it will be the B choice. Correct. 18. Corpora amyloidosis is a feature seen in histological section of. Important question है ये भी. The identifying diagnostic feature in a histological section of prostate. Remember. Now corpora amyloidosis, actually if you see it's a racemose type of apple-shaped gland in our gross view, but if you take a histological section you will find acini, and remember they are both mesodermal and endodermal. It's developed from both mesodermal and endodermal. So the acini, the benign acini, they secrete this pink colored colloidal matrix, and that is called corpora amyloidosis, right? And this actually is also called as, what is that, starch bodies. This also is called starch bodies. Starch bodies. And this is not only exactly feature of prostate, this you may even find in lungs, and this you may also find in brain sometimes. This is sometimes like seen in other organs also, corpora amylaceae. So remember here, choice 18, your answer will be D. Corpora amylaceae seen in prostate. For your added up knowledge, let me remind you something important, that there was another word like corpora arenacea. Corpora arenacea. Where is this corpora arenacea? This is a hallmark identifying feature of. It is also called corpora arenacea. Like corpora amylaceae is called starch bodies. Corpora arenacea. Corpora arenacea is called brain dust. Brain dust. And this is a feature of pineal gland. Pineal gland. So this was about the histological slide. So the answer to this corpora amylaceae will be prostate. It's done. Question number 18, answer is D. Then question number 19, among the hold on, yes, question number 19, among the following structures, which one is not derived from the mesonephric duct? So remember, mesonephric duct, say, what develops? It's actually the drainage or collecting apparatus of the urine from the kidneys, right? So I'm just fast reviving it about mesonephric ducts. Remember, kidney, drain urine drainage collecting apparatus, and that includes minor calyx, major calyx. Before to that, even if you remember, there was collecting ducts, duct of Bareilly. Don't forget, this is also called collecting ducts. Collecting ducts of kidney, they are also called duct of Bareilly. Then you have minor calyx, then you have major calyx, and then you have renal pelvis, then ureter, right? Then the trigone of the bladder, and then posterior portion of the prostatic urethra, prostatic urethra above the opening of those two ejaculatory ducts, right? And of course, there are like glands coming out from this portion reaching into this prostate. So the mesodermal portion of prostate, that also derived from this mesonephric duct. And now about another thing that develops here is the ejaculatory pathway. Ejaculatory pathway of sperms. And now this will be starting from here. Remember, ejaculatory ducts. Then you have ductus deferens. That's also called as vas deferens. Epididymis, seminal vesicles, right? And yes, all this. And vasa efferentia is actually mesonephric tubules, not from this. So this was derived from this mesonephric duct, and the portion of mesonephric duct which is the cranial most portion, like remnants. Now we're talking about the remnants. Oh, I think I should write it here so that you remember. रेमिनेंट्स में आ जाएगा अपेंडिक्स ऑफ एपिडिडाइमिस. I think very less of space. I'm writing it on my mobile. Epididymis, right? So appendix of epididymis or remnant of mesonephric duct. Got it? So your choices here among the following structures, which one is not derived from the mesonephric duct? So collecting tubules, I have just taught you. Ejaculatory ducts is also from this. Appendix of epididymis is also from this. So lastly, you should remember that appendix of testis is actually a remnant of paramesonephric duct. The duct which forms the female genitalia, like the fallopian tubes, uterus, and upper one-third of the vagina, that it all is derived from paramesonephric duct, also called as Mullerian duct. So one of the remnant in males from paramesonephric duct is appendix of testis, and another is, apart from this, there is another remnant, and that is called utricle of prostate. This is homologous to vagina in females. In males, you have utricle of prostate, or some say even compare it with the uterus or the upper one-third of the vagina. Anyways, so these two structures, utricle of prostate and appendix of testis, this is utricle and appendix of testis, both are remnant of paramesonephric duct. Hydatid of Morgagni, yes, this is also called as hydatid of Morgagni, appendix of testis. This can be an MCQ sometimes, remember this, hydatid of Morgagni. Okay, so this 19th is done. Lastly, we're talking is about this question about embryology. Transverse colon passes behind the superior mesenteric artery, and the duodenum crosses in front of it. This condition is due to fast revision. Normally, look here. Normally, what happens is this: what is this? Pancreas, right? So you know that there is this superior mesenteric artery emerging out here, and you have is superior mesenteric vein coming out here, and what you have behind is the duodenum like this. Duodenum is lying behind like this. So remember, this superior mesenteric artery and vein, they cross anterior to the third part of duodenum. This is the third part of duodenum. Now what lies anterior to these vessels is, using the green color for this is the colon. The transverse colon actually is anterior to these vessels, right? Or you can say the superior mesenteric artery and vein run behind the transverse colon. So that is a normal pattern, right? Normal pattern after the normal rotation of the midgut loop. Now, if this thing happens in reverse भी fast देख लेते हैं. ये हो गया pancreas, right? And here you have is the transverse colon हो गया. Then you have is the superior mesenteric artery coming out like this, and you have the superior mesenteric vein descending like this. So now what you're seeing is that these vessels are running anterior to the transverse colon, and what is happening that the third part of duodenum is now lying anterior to these vessels. उल्टा हो गया है. इसको ऐसे करके देखो तो इमेज याद रहेगी. That this duodenum is running anterior to these vessels. And what was happening here, that the transverse colon was running anterior to these vessels. So this was normal. So if it is happening opposite to normal, obviously it will be called, what will it be called? Reverse rotation. This will be called as wait. Yes. So, reverse is happening, that duodenum comes in front and the transverse colon behind. This is called reverse rotation. Then talking about the non-rotation thing and incomplete rotation. Obviously, non-rotation may what will happen? Non-rotation may, remember there was this midgut loop. This was having a, diverticulum, the vitellointestinal duct, and there was this artery, the superior mesenteric artery to the midgut loop, and these are the branches supplying. So this is the pre-arterial portion, this is the post-arterial portion of the midgut loop, right? That is all you can revise. Now what happens in later on, this is abdominal cavity, this is umbilicus, then there you find is the stomach and everything like this when you are behind. What happens is that the small loops of the small intestine, including the duodenum and everything, stays on the right side, and the loops of the large intestine, they stay on the left side. This condition is called non-rotation. Small intestine loops on the right side, large intestinal loops on the left side. This is non-rotation. Incomplete rotation may, what will happen? They might be partly the structures derived from the midgut may reach to the left side partly, and partly the structures derived from the large gut may partly reach to the right side. So that will be a incomplete rotation, right? And non-descent of the colon, cecum, subhepatic cecum, they are all called malrotation. So there are different terminologies. Let me tell you, incomplete rotation, I have taught you. Normal rotation is the normal thing, this. Reverse rotation, you are seeing it here. Non-rotation is this. And malrotation में something abnormal like subhepatic cecum हो जाएगा, ascending colon does not reach, like cecum becomes below to the hepatic region, and there are many other such maldevelopment, right? So that becomes a maldevelopment of the midgut, GIT, loops of the GIT. So you have familiar with all these terminologies regarding the rotation of the gut. So I think you understood about this diagram. You can take a screenshot. Now let's read it fast. Transverse colon passes behind the superior mesenteric artery. याद आ गया? Diagram देख लिया. And the duodenum crosses in front of it. This condition is due to, I have just now told you that this condition will be called as reverse rotation of the midgut loop. So 20, your answer will be B. Okay, so here I am done with this MCQs. Good luck for those who have attempted. Let's hope for the best results.